Thanks, Rosie. Welcome, everybody. I was just saying it's nice to see so many people online and also in the room. Okay, and you can hear us now. That's good. And my name's Luna, and I'm just here to chair this seminar and also to introduce our speaker, who's a visiting researcher here at our Welcome Center for Cultures and Environments of Health. And she's visiting from the University of Southern Denmark, where she's doing a PhD on a project that looks at polycystic ovary syndrome. And Julia's got a very interdisciplinary background. She's already has another PhD in history and Soviet design. And so it's really great to have her here working in our transdisciplinary space as well. So I'm going to pass it over to her. I think you're going to speak for about half an hour, and then we'll have time for discussion, and we can alternate questions from in the room and online. Thank you.
Okay, dear audience, dear colleagues at the Welcome Center and beyond, dear medical humanists, design researchers, medics, and people from all walks of academia and science, thank you very much for having me here today. Special thanks to my mentor, Luna Donzal, for initiating this seminar, and to Charlotte Bardell for arranging it. As Luna mentioned, I'm a visiting PhD student from Denmark. I'm pursuing a PhD in the discipline design culture. I do it after making a career as a design historian focusing on the Soviet Union. So currently, my discipline design culture is interdisciplinary studies of design. This turn in my career gave me an opportunity to learn ethnographic fieldwork and qualitative methods of analysis. I'm working on an article-based dissertation, and this talk is a presentation of my work in progress on an article aimed for Journal of Material Culture. Therefore, here I focus on materiality more than on design per se. Any comments or criticisms will be very welcome. Menstruation has increasingly been the topic of public and academic discussion. So has been metabolic health. And the colleagues here know it very well and engage in metabolism studies. Menstrual and metabolic health are not solely medical matters. They span the everyday lives of a significant part of the world's population. This everydayness of menstruation and metabolism is embodied and material. It involves numerous objects and technologies, and not only, say, sanitary products and blood glucose monitors. The objects of metabolic and menstrual care intersect at several points. One of them is polycystic ovary syndrome, known by abbreviation PCOS, which I will further use. This condition affects 5 to 20% of women and persons assigned female at birth worldwide. In spite of being a very widespread condition, the exact mechanism and the proportion of genetic versus environmental causes are not sufficiently known. But insulin resistance is considered a crucial contributing factor. Hence is the metabolic aspect of PCOS. This condition is associated with the elevated risk of metabolic syndrome, prediabetes, and type 2 diabetes. In 2003, a consensus on PCOS diagnostic criteria was reached at an endocrinology workshop in Rotterdam. This slide taken from the NHS page outlines these criteria. 2 are enough to give a diagnosis. Beyond these 3 criteria, there are multiple symptoms that can be present in different combinations. By definition, PCOS is not a disease, but a syndrome, an amalgamation of symptoms that require handling on a regular basis. In this talk, I draw attention to the seemingly self-evident daily maintenance of bodies that medical professionals designate as deviating from the norm, from the standard of health. My research is, of course, interdisciplinary. It relates to several fields of research, of scholarship. And I would point for feminist design history and design studies, which relates to my previous experience, which is a bridge between my previous and current experience. Then science and technology studies, human-computer interaction and feminist technology, femtech. And last but not least, critical menstruation studies, even though PCOS, of course, is larger than menstrual research in menstruation. My data consists of 17 semi-structured interviews with Denmark resident women, and I would just quickly note that in my pool, everyone identifies as a woman, and it would be great to include queer and gender non-conforming people, and in general have more diversity in my pool, and this definitely deserves team research, but at this moment I focus on the data I have, and we can discuss it later in Q&A session. So these women, aged 23 to 42, they live in different parts of Denmark, and they all have official PCOS diagnosis. And I also include ethnography, that is research on social media, but I do not pay that much attention to this part of materials of resources in this talk. And I analyzed, I transcribed the interviews and analyzed them via thematic analysis, which is popularized and explained by researchers Virginia Brown and Victoria Clark, the two psychologists who made this approach popular in social science. And I combined inductive and theoretical approach, which means that I had some theoretical concepts in my head while approaching the data, but I also paid attention to the conceptualizations by my interviewees. And now I offer a provocation. PCOS is a designed condition. It's a syndrome including at least 2 or 3 symptoms according to the decision of a group of particular experts taken in particular location and time. Of course, the variability of diagnostic criteria is not unique to PCOS. What is unique or specific is a range of combinations of criteria and associated symptoms. One person with PCOS may experience excessive body hair growth and elevated testosterone in their blood work while having their periods regular like a Swiss clock. Another may have 1-2 periods per year. They may behave as painful or not, and struggle to maintain their weight, but barely noticing any body hair. Yet another may be lean and athletic, but complain about constant fatigue and sugar cravings. Some PCOSers, due to rare and irregular ovulations, go through long, exhausting, and costly fertility treatments. Others have no problem conceiving, but feel extremely insecure about acne or about their body shape perceived as feminine. These combinations can vary endlessly. And if we imagine a PCOS support group, 2 of its randomly selected participants may find no common symptoms. One of my interviewees suggested the term symptom pack. This is how she described her impression from social media postings and internet articles on PCOS. Some were only about weight loss, and it wasn't concerned that much about that. And others were about tiredness and feeling depressed, and the ones that they looked most into were about irregular periods and unwanted hair. And I felt that most of them had in common blood sugar. Several interviewees spoke in similar terms. Notably, one interviewee referred back to my knowledge and understanding of PCOS. So she would say, you know yourself, there are so many ways this illness comes in. So she chooses the term illness. Or, you know, like, because this illness is so different from woman to woman. And yet another used the term multidimensional multidimensional disease, and there are a lot of things going on mentally and physically. And I did not speak much about mental symptoms, but we can also talk about it in Q&A. I find the term symptom pack to be a helpful concept that captures the specifics of an individual's PCOS experience. It also allows me to apply the concept of multiple bodies offered by philosopher Annemarie Mol to the case of PCOS. According to Mol, as she writes in her famous book, Body Multiple, the same disease of the same body can exist in different registers and be enacted in different locations. For example, hospital departments. As she explains, if a relation between the atherosclerosis of pathology, that is post-mortem examination of arteries, and the atherosclerosis of the clinic is made in practice, their object may happen to coincide. But this is not a law of nature. It may also happen that a patient who never complained turns out to be severely atherosclerotic at the postmortem. In such a case, the objects enacted in the clinic and in the pathology department don't map. They clash. One atherosclerosis is severe while the other isn't. One atherosclerosis might have been a reason for treatment while nobody ever worried about the other. And then she conceptualizes atherosclerosis not as many different diseases, but as a single multiple object. It's both single, it's one thing, but it's also multiple. It exists in these different enactments. Borrowing this concept, I related to one induced by my data, symptom pack. One symptom pack offers a multiplicity, but there is also a multiplicity across symptom packs. So this is how I suggest explaining it. The multiplicity of PCOS can exist within one body. For example, PCOS of the ultrasound, where we see the specific pattern of antral follicles, versus PCOS of oligomenorrhea, that is irregular periods, or it can be amenorrhea, missing periods, versus PCOS of elevated testosterone, glycemic hemoglobin, glucose, and so on, or versus PCOS of hirsutism, that is the excessive body hair. This multiplicity also exists across bodies. That is, as I already mentioned, different symptom packs are present in different patients. And this type of multiplicity is medically, in the medical language, termed phenotypes. There are several phenotypes of PCOS. And this twofold multiplicity affects daily material cultures. So that's my central argument. Now, I employ a pair of concepts, care and self-care, and I start from the latter. In human-computer interaction and in health humanities, the concept of self-care has been significant. Some authors in health research suggest an opposition between self-care as a healthy individual strategy to prevent disease and self-management as a set of tasks in day-to-day life with an already existing chronic illness. However, as Marina Wada and James Wallace summarize it, HCI researchers prefer using self-care broadly to include health management, both to prevent and to manage chronic illnesses. PCOS is a convenient case for challenging the self-care versus self-management dichotomy. In itself, PCOS is not a chronic illness. Nonetheless, it includes daily physical challenges and mental as well, comparable to those of chronic illnesses, while at the same time, PCOS increases the risk of developing chronic illnesses such as type 2 diabetes or uterine cancer. Therefore, in a very likely scenario, a person with PCOS would need to care for illness prevention while also managing the already developed illness or issues. Moreover, the border between the two types of activities is often challenging to draw. So this is for self-care. A different possibility to look at self-care and PCOS is through the concept of care as conceptualized in science and technology studies. In their volume on care in practice, Mol and her authors, Ingrid Moser and Jeanette Pauls, emphasize that practicing care is not inherently good or efficient. Care is not about improvement, but about constant negotiation and persistent tinkering in a world full of complex ambivalence and tension. That was the quote from them, and they speak about care as performed for others, but performed by some actors, some people and institutions for others. Furthermore, this vision of care radically entangles with technology. Instead of opposing warm and nourishing care to cold and instrumental technology, Mol and her co-authors argue that care as practice always includes technologies, what, from thermometers and oxygen masks to laboratory tests and video cameras, end of quote. I suggest considering design objects too as elements of care, especially because these objects often function as technologies, for example, a tweezer or a pack of birth control pills. An example from body hair where care and self-care interrelate. Many of my respondents sought medical help. They sought help through their GPs. They were offered several laser hair removal sessions in a hospital, but in this case, for example, and there are a few such cases, they complained that the sessions were so far in between that they didn't really see the effect. So that was an example of good enough care, or maybe not good enough care, but care performed through possible resources. We only can offer it that often. So they needed to involve self-care as well and use objects, material objects like tweezers. And then one respondent would detail how she got into this habit after being disappointed with the care offered at the hospital, and she uses not so much time every day doing it. Yeah, and that's important for her to get control over it. Just pause so that you can use the quote, read the quotes. Now, Fernanda Nunes and Geraldine Fitzpatrick, I hope I say the names correctly, researchers from human-computer interaction, make a division between medicalized and mundane self-care. Medicalized self-care is an extension of care from health authorities, of healthcare services. Mundane, on the other hand, is about the complexity of living with a medical condition and handling it in practice. And they say, rather than only pursuing clinical activities, people are juggling multiple goals, priorities, and issues because the condition is not something separate from their lives. And this term juggling rhymes with, conceptually rhymes with other terms these authors use, but also people from STS like Mol use in their discussion of care. And all these words relate to the everydayness and materiality also of handling certain conditions. Juggling, tinkering, balancing, adjusting, adapting, and negotiating. So these are actually keywords, not necessarily expressed as such, but this is how I could describe the daily lives of my interviewees. Now, three examples relate to nutrition. For example, cutting fast carbs is a genetic healthy eating advice. But if you really want to psychologically adjust to, for example, loving pasta, then you may want to make your courgette into pasta-like shape, and then you use spiralizer, even though it's not necessary and maybe it's even redundant. You can cook your veg in any form or eat raw. But if you really want to adjust to your habit of eating pasta, then you need this device. Tables with nutrients, they look like extension of medical care, but my interviewee got them not from her GP or gynecologist or dietitian for that matter. She downloaded from the internet, and then she used these tables with details about nutritional values of different vegetables until it became habitual and she no longer needed. So now at the time of the interview, she said she no longer needs this. It became the mundane, it became the part of the habit. We can also speak about it phenomenologically, if you wish. Then snacks is another example how you switch your habit, how you create a different type of mundane self-care or different element. Because, of course, healthy snacks can exist as, for example, carrot sticks or pieces of apple in a lunchbox. But if you still want to use commercially available packaging and eat healthier snacks than something sugary, then you go for something like pieces of dried pork, if you're not vegan, of course. And this is what one of my respondents showed me, that this is her snack, her daily snack. It's still packaged, it's still something to, to snack on, to chew, but it's kind of more keto friendly. And then the final example, it relates to acne treatment, because acne is also one of the physical manifestations of elevated androgen levels. And one respondent had systemic treatment of her acne, so through oral medication, oral retinoids, and the side effect was extreme dryness of her skin and lips, and she needed quite a big pack of Vaseline, and she told me that this one is the best, nothing available in Denmark matches it, and this one bought in South Korea, where she had to be traveled. So that's kind of a little bit of extension of adjustment to your daily life. And she also told me she has multiple packages of different sizes. She always has some kind of Vaseline and very strong moisturizer with her. Now, the final theme from thematic analysis after the multiplicity and the self-care is shame. And what happens to shame when it integrates in the mundane self-care? So Luna's book is, I'm sure, familiar to all of you at the center. And here we read about the combination of phenomenological and social science perspective on shame. And Luna spends great attention to the gender as well as race aspect of the body shame, the embodied shame. And I have this hypothesis that in the case of PCOS, there is a lot of shame. There was a lot of talk of shame in my interviews, but once it becomes a part of mundane self-care, the level of shame diminishes. And while, as Luna argues and refers to multiple authors, woman as such is considered a deviation from the norm, which is male, wild male, healthy body. In the case of PCOS, often, especially in this cis heteronormative paradigm, the PCOS body is considered a deviation and is framed as such in medical language. But the way of dealing with this shame is often through this mundane acts of self-care. And here there is an example about shame. And again, it becomes so easy, and the respondent became so skillful that she knows what to choose. She knows whether to use a razor or a tweezer, and it's just a routine. So there's not that much space of shame. The same respondent talked about carrying a menstrual pad with her all the time because periods are unpredictable and they can start at any time. She has some clues, but she still prefers to have it. And she referred to having this pad always in her bag. And what if she drops this pad, or some colleagues notice it? She says, I'm not afraid of something like this. I don't feel ashamed. Another example is again about body hair, and here it's more about at least addressing the shame and challenging the shame on the level of the closest circle. So she, in this quote, says, "I always just like to wear, you know, a long t-shirt or sometimes, so no pants, and especially because husband's friends always come over at night. They used to see me in just my sleepwear, which also doesn't include apparently pants, long pants. And always, I sometimes have hair on my legs. So this routine is not so regular in her case because she adjusted it to her preferences. And one day we spoke about, oh, why do I have that? And why do I not shave and stuff like that? That's always, so most of his friends know too about this. I'm not the one to holding it back from people. So it's similar, I'm not ashamed. And that also, this is a polemical question. It can be argued against, and we can talk about it now. Now, finally, after outlining these three themes, I would like to conclude with the notion of relatability. So how can you relate to someone with a different symptom pack? What if your symptom pack is less discussed, both by medical professionals, by the NHS or Mayo Clinic or whatever authority you take, up-to-date, whatever medical resource, or by social media, medical, non-medical influencers, so on. And on one hand, I heard that relatability is very important. And in one example, like in the green field, I asked about the ability to relate. And here is this moment of switching a bit away from the material, because this respondent could relate her material, mundane, daily experience to others through the non-material, through the digital, through internet. And she said that, yes, they even use this device or method, asking, how do you feel about this? Do you feel this and do you feel this? Then this might help. And then all the time they post something, I'm like, yep, I have that and I have that and I have that, like all those issues I can recognize myself in, a lot of it, most of it actually. So here is a relatability within the multiplicity. But then also some complaint, and regardless of the symptom pack, actually, they would find that something is under discussed, under stressed. They would say that is too much focus on fertility, especially relevant when you're 15, you're given diagnosis, you haven't even thought about having kids, and now you have to think about it. Or one respondent said that, okay, we talk about that much about trying to conceive, improving ovulation, but after you succeed, postpartum PCOS doesn't disappear, and what next? And it's not discussed enough. So she organized a Facebook group for discussing exactly that. And for others, weight loss is not such an issue, but in one case, and there were other pronouncements less direct about it, people care about the experience they don't necessarily relate to. So someone who has no issues with her weight would say, I really feel for people who get fat shamed instead of being really helped. So these different symptom packs can relate in different ways. So this is not really a very conclusive conclusion, but this is a work in progress. So thank you very much for your attention. And just want to give 2 examples of, again, non-material design aspects of PCOS. So these are the Instagram posts. One of them is by a Danish influencer who runs a page called Sisterskab. So that's like sisterhood. This kind of pun is used a lot in PCOS. And that's exactly, she has self-care checklists, what you do. And we discussed with Luna these different aspects of healthcare. How is it neoliberal, placing all the responsibility on the patient, or it's about agency and self-advocacy? So that's one of the questions that we could discuss. And in another examples, I believe it's British American count, and here there are some rules for routine that then any PCOS can choose whether to follow or not, whether it will be part of their mundane practices. So thank you very much.
Great, thank you. Excellent. So we'll open it up for discussion and questions. I've got the Zoom call open on my laptop so I can see anyone online. Do you want to just stop sharing so we can see everyone? And let's change it. Gallery. There we go. So yeah, open up for questions. Anyone in the room or online?
I have a question. Yeah, definitely. Yeah, so it relates to the, I think, the penultimate slide. Yeah, there was a statement, I think it's the first bullet point, that said shame is, I think it was quoting Luna's book, like shame is constitutive and necessary for acquiring bodily skills. And I was just really interested in that. I've just been kind of mulling it around in my mind. So I suppose the first part of my question is whether you could just talk a little bit more about why you included that and what you meant by it. And then I was thinking, sort of in relation to the rest of your talk, how, like, I understand the idea that shame sort of might be sort of a motivating factor in kind of acquiring the bodily skills necessary for these self-care practices. But then I was thinking, might there not be like many examples where shame is actually getting in the way of acquiring bodily skills? Because, you know, I think that statement, like shame is constitutive and necessary for acquiring bodily skills, it sort of suggests something generative about shame, right? Kind of suggests that shame will kind of lead, like, open something up or like generate something, I think. Maybe I'm misreading it, but I feel like it does. But yeah, I don't know. I guess I was just thinking about the ways in which I sort of understand shame as being a destabilizing force. Like, so might there not be like lots of instances where it's sort of more likely to lead to people not being able to engage in those self-care practices and develop those bodily skills. Yeah, I just wondered what you thought about that, really.
So should I respond one to one? Or?
Yeah, go ahead.
So yeah, it's a little bit tricky to answer this question in the presence of Luna, because she's an expert on different approaches to shame, especially with phenomenological interpretation. For me, it was very interesting to find this research, and I know there is also a collected volume, and I'm going to get deeper into it, because shame is one of the codes or one of the topics that I developed into a theme as a result of my thematic analysis. And even though they speak a lot about shame, I wouldn't call it the overarching theme. So their experience is not, first of all, about shame. It's about so many other things. And that's how I came to the idea that the mundane dissolves this shame. So in terms of acquiring the skills, it's in phenomenology and phenomenological interpretations of the body that is seen by others. And again, I really feel like I'm not going to try to summarize Luna's work in her sitting next to her. But what is important to, in relation to my case, shame, as described as not always the harmful part of experience, of human experience, of embodied experience, but also constitutive for acquiring self-awareness and development, well, some fundamental skills. In the case of when it's about the gendered body, and again, as Luna argues, the gendered body is more susceptible to this negative impact of shame and raised bodies. And actually have one example. Just in a moment, I probably it's okay if I bring it. There was one example in my interviews about also gender and raised body and kind of vulnerability to shame. So in this case, this chronic shame can push you towards making some extreme choices. And, Luna's case study of cosmetic surgery. So you would really intervene in the integrity of your body. And again, today, there are all these kind of this current state feminist discussions of the autonomy of the decision and reappropriating cosmetic surgery as me deciding what to do with my body. But that's a bit of another topic. In the case of PCOS, I believe that, yes, shame can be, of course, very impactful, and especially while the body hair and acne comes up a lot. The fertility which is in itself a very extremely sensitive topic, and it deserves really its own research. It's not in my focus, though, of course, I pay attention to it. With fertility, it's a different type of shame, probably it exists on different levels, but they all are defined by social norms, and Luna also talks a lot about it. The shame appears not only through the interaction of others and the personal perception as in phenomenology, but also because of the institutional and social structure. So there are many levels. And again, back to the core of your question, shame can really be debilitating. Whether you are trying to be vis-a-vis other people, you need to really decide. And that's what happened to my respondents. Do I shave my legs today? Is it warm weather and am I going to, go out? Or am I just at home? Am I just meeting my husband's friends whom I can confront with this statement that I don't do it? And that's why, and I can tell you about PCOS and what it means. I can educate you. So you stop being surprised by my unshaved legs. Or do I plug the upper lip hair because today I don't work from home and I go somewhere. So on one hand, it can be really disturbing because you have to decide every time. But when it becomes a habit, then you don't really, you just do it a bit automatically. And then there are different also scenarios. You can say, I own it. Okay, here is my tweezer. Or like my husband jokes that I should shave my beard. And that's okay because it's our inside joke. And it's kind of beyond shame. It's just who I am. So that's where I'm trying to arrive. But of course, it's a little bit of a chaotic answer.
Yeah, no, it's good. It's really, really interesting. I think my question was chaotic too. It's, just something about shame and bodily skills and the relationship between the two. I think it was a very self-indulgent question because this is something I'm really grappling with in my own thinking. So yeah, thank you. That was really interesting.
Yeah, with the race example, again, my pool is mostly middle class white Danes. There was one example, the respondent who's Black and who grew up in Denmark and who is like integration with society and speaks fluent Danish. She didn't really emphasize the race factor that much. She talked more about other aspects which were very ahead of her. Race somehow didn't come up, or she chose not to emphasize it. But she mentioned that one of her first symptoms was this black acanthosis, so the dark patches of skin, and they can be in different parts, especially like underarms or like skin folds. And when she talked to her GP about it, or it was a gynecologist, that doctor said, probably it's because you're Black, so it's nothing to be concerned about. And she didn't really emphasize it that much. It was like she listed it as a part of just not very, to put it mildly, nice experience, not receiving a lot of attention and a lot of information from the doctor. But I immediately felt like, oh my God, that's so terrible. So already a PCOS patient would often feel dismissed, and that's a very common topic in the interviews. And here you have this extra level of vulnerability.
Yeah, great, thank you. It's really fascinating.
Good, thank you. Any other questions online or in the room? Rosie?
Thanks, Julia. Now, I was struck at the beginning when you said 5 to 20% of women have a diagnosis. So presumably there's a broader range of people undiagnosed.
Yeah, exactly. There are some also overdiagnosed because it's a differential diagnosis. And of course, the medical guideline is that you exclude what could also cause certain symptoms. But there, in actual medical settings, there can be lack of competence, lack of time and attention. There can be both under and overdiagnosed. But under is more common.
Under is, especially because all of the symptoms you describe are within a scale of, rather than there being a cutoff, it's kind of a scalar thing where maybe someone would be somewhere along the scale towards diagnosis. Right. So the number of women who would experience some familiarity with some of those scales would be big, right?
Yeah.
And so that this makes me think when you're talking about self-care, that the people you interviewed are also involved in another type of care for the category of woman, of what falls within a healthy woman. So I think shame, or judgment at least, has more of a role there maybe than you're currently giving it, if that's a kind of fair front. One thing I wanted on a methodological level is with your sample, whether they're self-selecting to be those who are least feeling shame about their symptoms, although a kind of empirical question that tracks back to all of this going on out of your wonderfully rich talk is it doesn't sound as though any of your interviewees didn't shave. So I would have thought, I don't know whether that would be a marker of very low shame or what, but I find that empirically interesting because I know that there are, particularly among younger women, new waves of people who handle aesthetics differently and maybe don't shave even with or without PCOS. So so let me put this all back to a question do you think that there was a self-selection of people who don't experience so much shame in your sample?
Okay, I'll try to separate the question because I tend to a bit digress. So, but that's a great question, and you talked about shame, and then you talked about shaming. So that I'm sure, to be sure that I understood it correctly. First of all, the selection. I recruited my interviewees from support groups and also through these Instagram influencers. So of course it's a selection bias, and I didn't mention it just because I wanted to keep the time, but of course it's obvious. There are, I imagine, a big pool of people who, when given a diagnosis, they just say, okay, it's fine. For example, I'm not planning to conceive now, or I'm child-free. I don't know. I kind of eat healthy-ish. I don't care. So they just agree with the doctors who say, it's okay. It's very common. And those who talk to me, they are those unsatisfied with this representation, like, no, you dismiss me. I really have the symptoms and I care about them, or I'm really anxious about my fertility plans. I am very anxious about my future health-wise, whether I develop diabetes and so on. So of course, those who talk to me, they are more interested. They did some research, they enter groups, they follow influencers. I also tried recruiting people from groups for women, not related to PCOS or any women's health issues. And that was the unfortunate example when people started reacting and then just decided not to talk. And that's very understandable. They don't care that much about PCOS, about their PCOS. I had one interview from that type of source. And indeed, that interviewee very briefly outlined her experience. And sometimes my interviewees, demonstrate that they may be a bit confused about terms, and they can, for example, confuse PCOS with ovarian cysts, which is different thing. And this polycystic is a bit of a misleading title, but again, don't have time to talk about it much. It's not my aim to correct them or to say, oh, they are scientifically wrong. My purpose is to see what happens in the everydayness. So that respondent didn't talk about shame at all, didn't display any shame, and she apologized for maybe not being so useful because she doesn't have much to say. And they said, that's actually very interesting and very valuable, but maybe you can talk about what is important for you. And then she told me the story about her pregnancy and childbirth. So and this story didn't involve shame. So that would be, of course, great to have more people from outside of these very sort of communities than shaming. Of course, not every PCOS has this either elevated testosterone or manifested hyperandrogenism in terms of body hair. So it's not in every symptom pack, let's say. And those who do have this problem, it happened in my talk somehow very visible because, well, it's just convenient area to talk about self-care, for example. There are some people, and there are quite a few people who select when to shave or when not, and I gave examples. There was one interesting case when, even though at the beginning that person really worried about not being feminine enough, not being like perceived as like a real woman or is really womanly, then she even said something that was gender challenging. She said, okay, I just accepted that I have facial hair. And that's also me, that's my experience, that's how I am being a woman, and I just don't want to spend my time on it anymore. So that's kind of the choice of the mundane that doesn't include this kind of skillful, like in this other example. Of course, like if I go to ethnography, I can find example of, for example, sorry for that tautology, just an example from some, I think, American podcasts, like a non-binary person said, I really embrace my hirsutism, it's part of me, and I have PCOS, and that's not a problem, it's actually kind of something that strengthens my identity, but I didn't have such examples, because I guess I would need, it would probably queer people, even in Denmark, in such spaces as like PCOS support group, they don't feel exactly welcome because maybe these groups are so much focused on normative femininity. Mm-hmm. And I would need to go to queer spaces, and it would also invite some ethical challenges and a different focus. Mm-hmm. That would be also great. And there you probably would hear about shame in a different way. Mm-hmm.
There's a question from Judy in the chat, which I was also wondering. Hi, Judy. Or you can say the question.
I think actually Yulia has just answered it perfectly in response to the last one, because it was exactly the kind of thing I was interested in, just how how kind of that heteronormativity and gender normativity played out in those discourses. So she's just answered it. So you can move on.
Let's move on. Thank you. Any other questions? Yes, go ahead.
Hi, thank you first of all for the very interesting presentation. I was wondering, when you were looking into influencers, would you kind of, if you would make perhaps like a quick consideration, how would you compare them to what is called nowadays as expert patients? Mm-hmm. And my other question, when you were talking about self-care, on one of your slides, you kind of portrayed it as something non-medicalized with some pictures of chips, Vaseline, etc. And I was just wondering, like, self-care, is it always non-medicalized, or is it a kind of a different kind of medicalization? Because people with chronic diseases these days, they resort to, for instance, alternative medicine, or kind of like they try to take over their own care with, I know several people who read a lot of medical publications, for example, on their diseases, etc. So I was just wondering, like, is self-care something which we can separate from the medicalized realm?
Thank you for the questions. So first of all, expert patients, thank you for the term, because it kind of slipped from my mind. And I guess this is the very appropriate and the best term for some of the influencers. So here I didn't talk much about ethnography, but again, in my interview data, they still appear. It's inevitable. And some of these, for example, Instagram pages, I suspect also TikTok, but I didn't look into that space, are run by expert patients. And I guess it's quite common pattern in medical conditions to turn from an expert patient who shares their life story to a health coach who can also monetize this expert knowledge. So these people are very important, and sometimes it's them who run support groups. Like one of my respondents launched 2 Facebook groups in Danish, one about trying to conceive when you have PCOS, and another about postpartum experience in PCOS. And they actually, if someone succeeded getting pregnant and carrying the pregnancy and giving birth, then they would transit to another group. So it's all this space of expert patients. And there are also influencers who are medics, who are medical professionals, midwives, gynecologists, other medical professionals, of course, dietitians, nutritionists, and especially in the Russian language segment, I see a few gynecologists who also have PCOS, and of course, their narrative and their presentation would be quite different from expert patients. Then about self-care. I relied on the distinction made by a researchers on human-computer interaction, Nunes and Fitzpatrick, who talk about medicalized self-care. So they do say that, of course, actually in research in health humanities and also in human-computer interaction, in this research on health technologies, often self-care was exactly presented as an extension, or mostly as an extension of medical care. So that's not, and I am not arguing against it, and they are not arguing against it. They say, of course, or there is this type of self-care which extends the healthcare services. For example, if you need to monitor your blood sugar, you are doing it to kind of advance your communication with your GP and to report whether you've been compliant. I know, for example, taking medication or doing nutritional changes and so on. But there is also a space which is beyond the. That's a good question. How can you be really beyond? These 2 authors, they focus a lot on some habits and some tricks and tinkering that usually your GP wouldn't think about. One example is how you yourself make it easier to how you make it easier for yourself to remember taking the pills. And even though there are apps for reminders for taking pills, and some of them are issued by healthcare authorities, the Danish healthcare has such app, for example. People also have some other solutions. They place their medications in different visible spots and so on. Or mental health, even though, of course, mental health is a part that can be very much medicalized and managed by psychiatrists and so on. It's also an area which is often neglected in chronic diseases, and in PCOS, I heard some complaints from my interviewees that doctors don't talk about it and they need to handle the emotional challenges separately. But again, then sometimes they involve the psychological services and they get diagnosis, for example, of depression. So it's again medicalized. So I would agree that you cannot draw a very clear border between medicalized versus what Nunes and Fitzpatrick call mundane. It's always mingled, it's entangled. And when you tinker and adjust, it often about navigating between these two areas. And it depends whether your emphasis is on trust in the medical authority as against like alternative medicine, which you may find very suspicious, or whether you have a very bad experience with medical authorities and you want more autonomy from this medical space. So that can be viewed as kind of a patchwork or kind of an entanglement rather than the straight separation.
Thank you. Did you want to come back?
No, thank you. I'm satisfied with the answer.
Great, thank you. Well, we're almost 1 minute away from 3 o'clock, so we're going to wrap up. But thank you everyone for your questions, and thank you for your talk. And yeah, it's been a really nice session. It's been recorded, so we will have it available if you know any colleagues who might be interested. The talk will be on our centre's YouTube channel. So thank you all. Thank you again.
Thank you.